a quiz. I don't have a quiz as of yet, but if you're watching this as a recording, we'll get you a quiz when that's updated. And without further ado, Dr. Retallack.
All right. So I just wanted to give everybody a little bit of an update on antibiotics. It's something that's been come up a few times at a few conferences I've been to and has been a source of discussion on some listservs and in some groups. So just want to make sure we have some current information and some ideas about what to do going forward. There we go. So we're just going to give a sort of a brief overview of some antimicrobial stewardship again, understanding MRSA and MRSP and surgical infections. We'll get some guidelines for prophylactic antibiotic use, as well as some strategies for infection control and management and some key practices for surgery and surgical interventions. So first off, I wanted to just do a little bit of background information about what's going on around the world. And so there's this study, it's by the European Network for Optimization of Veterinary Antimicrobial Treatment, that gave a review. They had 34 studies involved in this review involving over 12,000 dogs. There was some variability in the protocols and definitions, as you would expect from having multiple studies involved. And they basically found that there really needs to be some sort of standardized, excuse me, data collection and agreement on what is in a surgical site infection in order to better start classifying them so that we can get some more information from them. It also gave some institutional antimicrobial stewardship guidelines, so regulating the critically important antimicrobials, gave us some guidelines for in different tiers of antibiotics, recommended some restrictions on availability and use to prevent misuse, and then also promotes adherence for appropriate antibiotic use. And in the States, we have some guidelines from AHA and the American Association of Feline Practitioners as well, too, sort of like position statements, basically. So antimicrobial resistance with surgical infections, MRSP is, oh, this seems like this skipped ahead a little bit. Yep, here we go. The prevalence in veterinary medicine of MRSP, which is probably the most common resistant infection we see, is anywhere from 0 to 4%, depending on the studies you read. And I think it's pretty incredible that some studies came up with 0%, considering what we're seeing clinically. So I don't think that number is quite reasonable. I think more like 4% is more accurate in the population. For the studies related to dogs presenting to dermatology services, the incidence of MRSP has been reported in up to 40% of those cases. Again, typically those are derm dogs, so they've been on antibiotics before, so there's a higher chance of them having a resistant infection anyway. Thought it was interesting, some of the studies showed a higher prevalence in feline samples compared with dogs, but that study was also out of Germany, so it's a little different perhaps than our population here. And they've also found a high co-resistance to both clindamycin and TMS, as well as increasing resistance to chloramphenicol lately. And so we have kind of limited treatment options for some of these really nasty MRSP infections. So MRSA and MRSP, they're pretty similar. So generally, we kind of extrapolate what we know from MRSA in humans. MRSA itself, because this is a common question that you get from clients, can be transmitted between humans and pets, but typically pets who live with MRSA-infected humans become colonized, but don't necessarily develop true MRSA infections. And those pets who are colonized with MRSA can cause recurrent infections in their human owners too. There's been documented cases of this going both directions. And when they have isolated true MRSA from cat, they did find it the exact same strain in its owner as well too. MRSP, by comparison, is generally from pets to humans, and it's primarily on dogs, and it's really rarely been identified in humans. I haven't found really any studies that really associated that. So generally, when clients ask me, I tell them it's not much of a risk, but if anybody's immunocompromised, they should always be careful anyway. And then you also want to take into account the environment and minimize the risk of transmission to other pets in the household or other people who are at risk. So first off, I wanted to just take a look again at what do we do for MRSA in humans? What are the standards on the human side of things? And maybe we can kind of figure out what we should be doing in veterinary medicine from that standpoint. So these are the recommendations from human orthopedic surgeons from a variety of different organizations and sources. Basically, they get prophylactic antibiotics, a single dose of IV antibiotics within 60 minutes of the initial incision. If they're getting a vancomycin or fluoroquinolone, then they get that a little longer before the incision. They almost always stop antibiotics within 24 hours. Most of them only just get perioperative antibiotics. And they generally recommend strongly against extended post-surgery use of antibiotics. So putting them on an antibiotic prophylactically for 1 to 3 weeks. For total joint replacement, so things like total hip replacement, total knee replacement, these guidelines are pretty much the same. So just a single perioperative or preoperative dose of antibiotics, discontinuing those within 24 hours of surgery and not recommending continued use. There were some sort of case-by-case bases that I found where if they're have an open fracture or something like that, then potentially they consider antibiotics for a little bit longer. And same thing for dental procedures. For the most part, they've kind of gone away from giving antibiotics for much more than one dose at most. So the CDC has some guidelines for MRSA, generally starting with contact precautions. So if you know somebody who has a MRSA infection, wear gloves, gown if appropriate, keep equipment used on that patient just for that patient, and then sanitize in between uses. Wash your hands, use alcohol-based hand rubs or wash with soap and water. Generally, that's a good guideline between touching every single patient. We should be wearing gloves and, if possible, washing your hands or using hand sanitizer in between patients anyway. And then really important is decontaminating the environment. So the hospital room where this patient stays, everything in the room gets thoroughly cleaned, especially high touch surfaces or places where the wound could have been exposed to. And then in humans, they also are big on chlorhexidine bathing. So they give you a scrub to take home and wash with before surgery and after. And they'll sometimes do that for patients who are hospitalized as well. The CDC also has some recommendations for topical therapies. And ideally, if you can treat a patient with MRSA topically, that's the goal. We want to try and avoid systemic antibiotics because these really seem to increase the risk of infections. So any sort of topical wound or incision or things like that, they'll do mupirocin, chlorhexidine bathing are usually their first go-tos. They use intranasal mupirocin a whole lot in humans as well too. If it's a deeper infection that there's not realistic to get to topically or get some sort of treatment to that way, then it's really based on the culture. Sometimes they'll make a empiric choice based on what they think it is, but typically they try to culture and get antibiotic sensitivities before starting antibiotics. Especially also if it's a resistant or recurrent infection. If it's something that's been ongoing, then they'll really try to get a culture before they try anything systemic. And occasionally for really severe cases where the patient's potentially at risk of becoming septic or something like that, they'll do a combination of topical and systemic treatments. So the American Association of Orthopedics have pretty much similar recommendations. They've just adapted it from the CDC.
The
So
orthopedic
they'll
surgery
screen
listeners.
patients if they're concerned at all before surgery. So they'll collect a culture, they'll apply intranasal mupirocin, they'll recommend chlorhexidine bathing. I know when I've had surgery in the past, regardless soft tissue or orthopedic, they generally recommend you wash with chlorhexidine for at least 2 showers before your procedure. So it seems to be pretty standard. And a lot of the soft tissue people seem to have adopted the orthopedic recommendations as well too. Like when I had laparoscopy, they had me do intranasal mupirocin as well too. For the preoperative skin preparation is basically what we talked about. So some full body decolonization. And then intra-op, obviously it's surgery, so you want to maintain a septic technique. They give one dose of prophylactic antibiotics within 60 minutes of the incision, and then they discontinue antibiotics within 24 hours unless there's a positive culture that indicates need for continued antibiotics. So generally, this is sort of a summary of the key practices from the human side. So contact precautions, Hand hygiene is super important for people who are going between patients. Environmental decontamination, so cleaning all of the surfaces very well. Chlorhexidine bathing, if possible, for the people. And then especially if you're going to have something like a joint replacement, they'll consider preoperative screening, so culturing your skin or something like that, maybe even decolonizing you before surgery, preparing the skin appropriately for surgery, and then just 1 dose of IV antibiotics during. So when you get an actual MRSA infection, though, they also have some guidelines for us. So first off, if you have an abscess or something like that, an obvious pocket that has a MRSA infection, the primary treatment is incision and drainage. So opening it up, flushing it out, getting rid of all of the purulent exudate, reducing the bacterial load, and moving forward from there. Then the next important step that they focus on is getting a culture. So that's obviously part of the drainage procedure. So you want to get some samples of the fluid, get a culture, identify the causative agent, and then get it on appropriate antibiotics. Depending on what they're seeing, they're doing a lot of cytology and things like that. They get results a little bit faster than I think sometimes we do in veterinary medicine. So they will start empiric antibiotics if they need to, but oftentimes they try and wait for some culture results. And again, they kind of base that on what they think is causing the infection. If they think it's going to be a MRSA, they might treat it a little differently than if they think it's a Pseudomonas or something else like that. And then finally, the duration of therapy really depends on the severity and depth of the infection, as well as how well it responds to the treatment. Superficial infections, as we know, generally require shorter courses, whereas deep or really systemic infections, sepsis, those kind of things probably are going to need significantly longer therapies. So the decolonization strategies in humans really are just bathing the patients with chlorhexidine. And there's a few different things. There's Hibicin solutions, there's wipes. They'll send people home with essentially hand scrubs. Basically, they want to just reduce the colonization. So you wash your whole body with that over and over again. And then they'll send home intranasal mupirocin as well, too, because we've found that that definitely is the source of a lot of the infections, kind of a reservoir of MRSA in humans. Their infection control measures are pretty similar to what we talked about. So using gowns and gloves, practicing proper hand hygiene, have a clean hand and a dirty hand, for example, if you're cleaning a wound. So the hand that's using the chlorhexidine gauze and cleaning off the wound, use a different hand to get your clean chlorhexidine squares, pass it to your dirty hand, and then wipe the incision or wound with that. And then really paying attention to contact times with your disinfectants, cleaning all of the surfaces appropriately, using those contact times, and just making sure you're actually decontaminating the full environment so you're not transmitting it to other patients or around the place. So basically, the treatment approach is surgical intervention, antibiotics as appropriate based on your culture results, decolonization of the person, and then controlling the environment as well too to prevent infection in somebody else. Looking into it, the European guidelines are really quite similar. So they screen, recommend decolonizations, they recommend empiric therapy if you're waiting for culture results, but really want culture-guided therapy. They have contact precautions, environmental cleaning, hand hygiene, all those things are essentially the same thing. Maybe they have a little bit more in terms of vancomycin as an additional antibiotic, only in extreme circumstances, but otherwise it's pretty similar. I was also looking for some different things around the world too, because some countries, particularly European countries, are really strict about what antibiotics you can use and when and how. So Denmark, I thought was interesting, has a really detailed records of antibiotic usage and resistance since 1996, which is a pretty long time. And they have data linked specifically to veterinary prescriptions, typically for ag animals. And they have really strict regulations in agriculture. And so they've been preventing the use of antibiotics for growth reasons in ag animals for a very long time. They're one of the first countries to seem to jump on board with that. Sweden's really similar. They also banned antibiotics in ag animals for growth starting in 1986, so quite a long time ago compared to the rest of the world. And they have a really individualized treatment approach for their use of antibiotics. So over 90% of antibiotic treatments are administered individually, which means they don't just prescribe antibiotics to a whole herd of dairy cows, for example. And their goal with this is really to minimize unnecessary exposure. The Netherlands and France are pretty similar, though not quite as strict as Denmark and Sweden. The Netherlands has a lot of benchmarking and accountability. They like to identify high users or prescribers of antibiotics and then implement disciplinary actions against them. So in the Netherlands, you could have the licensing board come for you if you're prescribing antibiotics too much, which I thought was interesting. And they've also, along with France, set a lot of different reduction targets and national action plans to try and reduce the amount of antibiotics that are used and prescribed. In France, the healthcare institutions also have to report how much they use antibiotics. And I presume from the way they wrote about it that there's potentially disciplinary action or follow-up against them as well, too. Australia generally pretty well aligns with the restrictions from around the world. They really restrict fluoroquinolones, though, for pretty much any animals. So they really want to preserve those for human use only and only in really necessary circumstances. Thailand, I thought was interesting. They have a lot of government oversight and infection prevention programs, and they really regulate their antimicrobial distribution. So you can't even get the antibiotics unless they think you need them, as a healthcare provider, that is. And they have a really high portion of their hospitals involved, over 80%, and they have a lot of commitment to combating the resistance and community education. Similarly, this province in India has a lot of really extensive public awareness campaigns, which I thought was a little bit different than a lot of other places around the world. So the general public really gets to know why or why not you use antibiotics. And it's really trying to help promote public awareness so that way people aren't coming in asking for antibiotics inappropriately. Overall, sort of these global efforts, the WHO has some programs here, sort of a One Health approach, trying to promote holistic health management for veterinary and human patients. And basically, it just recommends medically important antibiotics. So stop using them in farm animals for growth, which generally I feel like most of us can agree with that. And really trying to combat resistance and encourage collaboration and appropriate use of them overall. So the next thing after looking at the human side of things, I was like, okay, so what about veterinary medicine? What does the CDC and everybody recommend for MRSP? Well, these are the CDC MRSP recommendations. Nothing. Same thing with the WHO. What recommendations do they have? Well, essentially nothing. So there's really nobody giving any guidelines about what we should be doing in veterinary medicine. And none of the organizations even have a web page dedicated to it. There's nothing on the CDC or anybody else's website about this. So what should we do? So there's been a few studies that just came out or are in the process of being published from JAVMA that I thought were really interesting. And they're talking specifically about antibiotic use in veterinary medicine for multi-drug resistant infections. So this one was a really good study. I thought multi-drug resistant wound infections are associated with greater mortality, larger costs, and longer hospitalizations than susceptible infections in canine patients. And the odds of a longer hospitalization was almost 3 times. Mortality rates were almost 12 times as high, and total costs were 3.5 times as high. So that's a pretty significant impact for our clients and our pets. And of these species, they most commonly found staph, so essentially MRSP in 31% of these infections, E. coli 15, and Enterococcus in just under 11% of these resistant infections. And so of these infections, I thought the antibiotic sensitivities was really interesting. Almost all of them were resistant to penicillins, but 100% of them were resistant to Clavamox. Macrolides, so things like erythromycin, was 83%, sort of the third largest category there. And then fluoroquinolones was almost 60%. So definitely increasing resistance to the antibiotics we use most commonly. This study was looking at reporting style, which was a different approach, and then consequently how clinicians made decisions. And so basically, they're saying that how you report your sensitivity profiles can help clinicians be good antimicrobial stewards, basically help them prescribe the correct antibiotics instead of just choosing one. So instead of reporting just a big blank line of sensitive to all of these different things, they recommend cascade reporting, which tends to be the standard in human medicine, which says, do this first. And if this is resistant to this, then here are some secondary or tertiary agents that you can turn to. So it just basically tells clinicians more directly what antibiotic to use from the beginning to help guide decisions. So if it is sensitive to, say, ampicillin, then let's give ampicillin. Let's not jump to enrofloxacin or something else. This was a really nice chart about specimen handling from this paper, and I can share it on the P drive for everybody, but it basically gives you a really nice visual display of how to process and handle samples, because that's so important to getting good results. As the pathologists like to say, garbage in, garbage out, right? So having a good sample that's appropriately collected and stored before submitting for testing makes a big difference. One thing I like to mention to people when you're sampling joints, I like to use a blood culture vial rather than just a swab. Joints in particular tend to have low cellularity and low yields from cultures, even if they are actively infected. And so the bacteria seem to grow a little bit better in the broth if you put it in a blood culture vial. And then sampling appropriately using the right size swab, using the right storage container, storing it in the refrigerator or otherwise processing it appropriately. On the human side of things, if the sample arrives at the lab and they feel it hasn't been handled appropriately, like either not in the right media or potentially not stored correctly, not shipped correctly, not within the correct time window, anything like that, the lab will actually throw the sample out and the human physician will have to go back and resample again. So they're really strict about that on the human side of things, and it's something to really consider on the veterinary side, so that we're not sending in things that maybe aren't going to be helpful for us. This study was looking at antibiotic use in cats and dogs presenting to the US, primary care and referral practices. So basically, it took a sampling of 52 non-academic primary care and referral practices, and it took 1 day in practice at those clinics and looked at every patient that came in. The results was just under 2,600 dogs and cats, and it looked at how the providers prescribed antibiotics for them. And they found that in almost 30% of these cases presenting for the day for any reason, almost 30% were prescribed antibiotics. Meanwhile, only about 13% of those who were prescribed antibiotics had a culture performed. So basically, lots of animals are getting antibiotics for a variety of reasons, and very few are getting a culture. So one thing I wanted to point out, I couldn't find any good studies showing this, but it's been the subject of discussion at a variety of conferences I've been to for the past year, and it's definitely something we've noticed in our clinical patients here. For MRSA infections, chloramphenicol resistance is coming, which means that we're basically left with amikacin, occasionally imipenem, and occasionally gentamicin as our only real treatment options for these nasty MRSA infections, which isn't really great. Means that we have very limited options for these guys, and we need to come up with some new strategies to combat these infections more effectively without relying on systemic antibiotics. So, since there wasn't really any guidelines for veterinary medicine, I wanted to try and look at some of these human protocols and see what things we could adapt to veterinary medicine. Some things are certainly quite easy. There's some basic contact precautions. So wear gloves, wear gowns, don't walk these patients around through the whole hospital. Clean off whatever environment they're in, especially if you're changing, say, a bandage or something like that, exposing a wound to the environment. So make sure you're cleaning off any gurneys, spraying and wiping down the exam rooms, that kind of a thing. If you can, try to have them come in one specific place, do the bandage change there, and then have them leave so you're not having these patients walk around the whole hospital. Hand hygiene in general is really important in veterinary medicine. I think we all appreciate that. Wear gloves and use hand sanitizer between every patient. Wash your hands with soap and water. You know, we all remember the COVID restrictions. Wash your hands for 30 seconds, that kind of thing with soap. Preoperative screening is a little tricky. I think if we were doing more things like total hip replacement, we'd probably be focusing on this a little bit more. But generally, we don't really screen our patients for MRSP or anything like that, but it's something we could consider, at least in patients that we've known to have a resistant infection. Honestly, in my experience, clients who've had a pet that have developed an incisional infection with a resistant bacteria, say like MRSP, generally are hesitant to do surgery again, understandably. So it's something to consider, but oftentimes those clients aren't really looking for surgery again anyway. Intraoperative measures, I think we generally do a pretty good job of this. We maintain aseptic technique. Victorian Pack Prep are really, really good at maintaining our biologic and chemical markers for our autoclaves to make sure everything is appropriate from that standpoint. We all know aseptic technique, and if anybody has questions about that, they're certainly more than welcome to come find any of us in surgery, myself especially. I'm happy to chat with you about things you can do and how to maintain aseptic technique. We also do a good job with perioperative skin preparation, the different chlorhexidine and then chlorhexidine alcohol preparations we use do a really good job. We don't really have patients wash with chlorhexidine ahead of time. So that's something to consider. Same thing with decolonization strategies. So intranasal mupirocin or chlorhexidine bathing for carriers. We don't really do that in veterinary medicine, but it might be something to consider, at least if we have patients that we think are riskier. So generally, what we've thought of in veterinary medicine is don't shave the patients. This is a little counterintuitive, but if you shave more than 60 minutes before a procedure, you actually release more bacteria from the hair follicles. So we don't recommend shaving any more than 60 minutes before the procedure. So basically at the time of anesthesia. Along those lines, you want to be gentle when you're clipping. The more you traumatize the skin, more bacteria is going to come out. Chlorhexidine is really based on contact time. So alcohol is sort of an instant kill, the idea behind that in skin preparation techniques, but you don't really want to alternate alcohol and chlorhexidine, especially if you do alcohol afterwards, because you're just wiping off the chlorhexidine and you're not letting it sit and do its job and actually decontaminate the surgical site. So generally, I recommend just doing a quick wipe with alcohol, if at all, for the preparation, and then making sure you wipe with chlorhexidine and leave it on for at least 2 minutes before removing it. And so honestly, what we end up doing is we just prep them with chlorhexidine out in pre-op. We leave the alcohol swabs, or excuse me, the chlorhexidine swabs right over where our incision is going to be, and we just leave that in place while we roll into the ORs to keep it as clean as possible and give it plenty of contact time. And then we do our prep in the OR as well too with the pads. Intra-op, some basic things that we've known about in surgery for a long time. The more people that are in the OR, there's a higher contamination rate. Higher OR temperatures are associated with higher infection rates. So that's partially why the ORs are as cold as they are. Having positive airflow pressure through the ORs reduces infection rates. Reducing anesthesia time, the longer they're under, the more that their skin or whatever is open, the more risk of infection there is. And then another thing that's important is just picking the right antibiotic based on your surgical site and what you're concerned about forming. For the vast majority of these, we're just worried about skin contaminants, so staph essentially. Moving into our surgical field, so cefazolin is our go-to. It's really good for those just general skin bugs. If you're in the lower GI tract, you're worried about bacterial contamination from a really nasty UTI or something, you're doing colon surgery, something like that, you might want to consider a different antibiotic. So cefoxitin, a third generation cephalosporin, or Unicin might be the options for those. If you have a patient that's known to have a MRSP infection, so say you have a surgical site infection you're dealing with and you already have culture results, basically use the antibiotics from your culture. Use an IV dose of whatever those antibiotics are if it's available. What a lot of people are recommending from the pathology side as well as from the orthopedic surgery side, a lot of people, if they're, say it's a TPLO or something with an implant that's infected, will go in surgically to remove those implants and flush and clean out the area. A lot of the recommendations are just to give one single dose of amikacin. And the reason behind this is we're removing the source of the infection by removing those implants. So theoretically, their body should help resolve the infection from there. So if we just remove those implants, then that is really the most effective treatment for the infection. And then just giving one perioperative dose of amikacin shouldn't have all the negative side effects of amikacin chronically on the renal tracts and everything else. And it might just help with an extra kill for those bugs that are left behind. If you're dealing with something that's a little bit more chronic, like more of an osteomyelitis situation, or if you can't take out the implants, we've got one old and two new options for them. The old school technique would be using a wound soaker catheter and injecting antibiotics locally through that once or twice a day, depending on what antibiotics you're using. I've also done regional lymph perfusion a couple times for a really nasty implant-associated infection, mostly back in my residency or my internship. And that it's a little bit variable. There's not any good studies on the dog or cat side about how to do those. We just sort of extrapolated from horses, but that's an option. We also fortunately can use antibiotic impregnated beads, and I've done this on a number of cases now. Or what we do is we take out the implants, we mix up these beads, which are sort of like calcium beads, and then we add antibiotics into those based on our culture results. And then we embed those beads right at the surgical site. And the idea is that we're going to have a local diffusion of those antibiotics. Consequently, we're going to treat the infection more intensely locally. We assume that it will still travel systemically, but it seems to be really reduced in terms of systemic effects compared with local. But the beads are absorbed kind of variably. And there's two different size beads you can make. You can make either 3 mm or 5 mm. The 5 mm theoretically take longer to dissolve. In the cases I've done it in where we've radiographed them again post-operatively, all the beads have been gone by a month post-op. So I think our duration of action is not as long as you might think. They're probably absorbed pretty rapidly within a week or two. And I would guess that most of the antibiotics are gone by that point too. One new option that we've only done, I think one case here, maybe two, is these Vetland pouches. And so it's sort of like a combination of a wound soaker catheter in that it's a little pouch with a tube connected to it, kind of like a JP drain that attaches to um, a syringe on the outside. And what you do is you infuse antibiotic into that pouch, and then the pouch slowly releases it. And the idea is that you give them, say, amikacin once a day through that. It has, again, more local effects. It doesn't spread as systemically, but then it sort of slowly diffuses. And the idea, according to the company anyway, is also that you're going to get a longer duration of action with these Vetland pouches. So because you're infusing it every day, they're getting more local therapy. And so it's going to be a little more of a consistent response compared to the beads. And it's something you could, depending on the owners, have them do at home as well too. So generally, I think we can take the basic things away from humans. So stop antibiotics within 24 hours of surgery, keep incisions clean and covered. I really like the BioGuard bandages on every incision for that reason. Wear gloves when handling patients and change the gloves between each patient. Don't touch other things in the hospital in between. Wash and sanitize your hands between each patient, even if you're using gloves. And then clean items that are shared, like Dopplers, ice packs, anything like that should really be cleaned. It just takes a couple seconds to wipe them off with something or spray them in between patients. For those patients that you think are high risk, consider your antibiotic use carefully. They might be higher risk because they have diabetes, but are you really that worried about them? Do you really need to continue antibiotics beyond that? Just consider it carefully and make your decision from there. Honestly, the majority of these, if they're well-controlled diabetic or well-controlled cushingoid patient, then I usually don't continue post-operative antibiotics. Occasionally I'll have them treat the skin topically, but that's about it. And I really think from the studies we've seen lately, we really need to be culturing. Always culture any of these patients that you think there's an infection on. Get a sample of it, flush and clean out that area. That's going to be your best antimicrobial therapy, is just cleaning out the infection to start with. Ideally, really think about, should you start antibiotics, or can you just wait until you get your culture results? If you flush and clean it, maybe you can send them with mupirocin or chlorhexidine, something to do topically, and just while you wait for your culture results. So here's a little flow chart. I just kind of put it together. So thinking about, do we really need systemic antibiotics? First off, you want to ask, how deep does the infection go? If it's superficial, if you can see it and get to it, really, let's just do topical therapy. Let's not do oral antibiotics. If it's much deeper down, you can't get to it, then consider systemic antibiotics. Next question, which gets a little tricky, are there implants? So is there a TPLO plate? I say consider carefully. I'm leaning against giving systemic antibiotics for a lot of these, but it really just depends on a case-by-case basis. And really just ask the surgeon involved what their preference would be, but it's something to think about carefully if you really need them or not. Um, is the patient already on antibiotics? If so, then you probably just want to wait for your culture results. It doesn't make sense to expose them to a few doses of a lot of different antibiotics. It doesn't make sense to change antibiotics all the time because you're just making more resistant bugs. So ideally, don't do that. If they're already on Clavamox, keep them on Clavamox and just wait for your culture results and flush it out in the meantime. And then the last question, of course, is, are there comorbidities? Are there other things that can be contributing to their infection? Could they have a underlying infection somewhere else? Do they have other issues going on? And just consider carefully whether you really need antibiotics or not. So let's talk a little bit about empiric antibiotics for incisional complications. Um, you really want to base your antibiotics on what you think is causing the infection. So if it's an incision, most of the time these are skin bacteria that are contributing to the infection. So staph species are by far the most common, gram-positive cocci. Consider MRSA as an option. And basically, think like, what antibiotic would you want to give for this? Generally, it's going to be cephalexin, maybe Clavamox, something along those lines. If you think that they're really infected, consider carefully before you add enrofloxacin because most of these are resistant. So it's really not necessarily giving you any more protection if you add Baytril than if you just flush it and clean it out. And a lot of the times, Baytril has been shown to have a really increased resistance as well too. So the more we use it, especially for 1 or 2 doses in this kind of situation while we're waiting for our culture results, the higher the Baytril resistance is. So really getting away from using enrofloxacin much at all unless we have a culture that says it needs it. So wounds often get infected. They all, at some point, any of these chronic wounds that are open, they become infected, and it's just the nature of them. They're exposed to the environment, you're doing bandage changes, the skin is exposed, so they almost always become infected, and then they often become resistant because these patients are exposed to so many different antibiotics for such a long time. I always recommend flushing and topical treatment. Do it as you've got great access to the wound bed. That's where the infection is. So let's treat it where the infection is. So mupirocin, SSD are great go-tos. Just chlorhexidine is great. Silver impregnated dressings are wonderful, and those also are quite antimicrobial. Make sure your bandaging is appropriate. That's important as well too. White blood cells work the best when they have a low oxygen tension and high moisture content. So trying not to do wet to dries, generally that hasn't been standard of care for a while now, but trying to do some sort of moist wound healing where you don't change the bandage every day, or at least don't change the primary layer. If you put calcium alginate or something like that over the wound bed, you want to leave that in place for 2 to 3 days at least, sometimes longer than that, and just change some of the dressings on top if it's really exudative. Culture and then treat based on your culture results. That's also the important thing. If your culture panels, if your sensitivity panels don't have mupirocin or some of these other antibiotics you're looking for on it, just call the lab and have them run an extended panel because a lot of them will also report sensitivities to mupirocin and things like that as well too. So if a wound starts to appear infected again, ask yourself, go through the list of questions. Is the patient on antibiotics? When was the last culture? And are you treating it locally appropriately? Those are probably the biggest things. The compounding pharmacies are doing a whole lot for us now these days. We can make amikacin into a topical gel. I believe you can make imipenem and some of the others that way as well too. One of the less common antibiotics, I want to say it's originally from aquatic medicine for fish. It's called like triacide or something like that. That's something that sometimes we're combining topically. So there's a variety of options, but if you have a wound and you think it's actively infected again, let's think about what our topical treatments are and what we're doing and how we could do it better. Is our bandage appropriate? For really exudative wounds, the wound vac is a great option. It removes those that fluid and all that goo that's coming out of it, but also keeps it covered, makes a nice environment for the white blood cells to do their jobs. And we can also use silver impregnated dressings for the with the wound vac too to have a local effect. So overall, I just want to conclude that we need to practice good antibiotic stewardship. We don't have any guidelines in veterinary medicine. We don't have any organizing bodies really regulating us or even giving us information about these. So it's kind of on us to do that. Really think about, should I be using antibiotics? Do I really need them? Does this patient really need Clavamox to go home? Just because it makes us feel better isn't really a good reason. And that's honestly going to start making us not feel better anymore soon too, if everything's resistant. Use good hygiene, both for yourself and for your patient. Use gloves. Treat the local infection as much as you can. And then I think a really key component to this is client education and outreach. So really talking with clients, because sometimes they get pushy. If there's redness or anything around an incision, they're like, oh, we need antibiotics. No, you don't necessarily. You need your dog to stop licking the incision, actually. So reaching out to our clients, explaining what resistant infections are, what that would mean for your pet, and even presenting it from a financial or mortality standpoint, I think can be useful as well too. And educating them that we really only need to use antibiotics in certain circumstances, and we really, really need a culture to guide our antimicrobial therapy. So with that, I think that's the end. We have some time if anybody has questions or anything like that, Danielle.
Um, I haven't seen any come across the chat, but no, nobody has any in the chat. I have personally a couple of questions.
Yeah.
Um, when we don't do joint taps obviously very often in radiology. We occasionally will do something ultrasound guided, but are you using
Mhm.
the very tiny ones for your joint taps for the blood cultures? You're not using the big ones, right? The big
The
broths,
big one.
tiny
The big
ones?
one.
You are? Okay.
Hmm.
Um,
Yeah.
and then my question was regarding, one of my questions was regarding clipping, shaving prior to surgery. Is that other areas of the body? Like, are you concerned about like when we're shaving like ultrasounds and then you go and do a different area
I mean, a
randomly?
little bit. Theoretically, it could increase the bacterial contamination just on the skin in general. I mean, I guess if we're doing, say we're doing a TPL, we're doing a leg and you're shaving the belly, it's probably not a problem. I don't know. And on the human side of things, they'd have you bathe multiple times beforehand, either way, regardless, right? So maybe that's something we should be considering, or at least doing like the Duoxo mousse or something like that after you shave, put some of the mousse or something on them. The nice thing about the Duoxo, I find, is that at least Derm tells me it lasts for almost 2 weeks on a normal patient. So it has a bit of an antimicrobial effect for quite a while. I just don't know how to tell people to do this when they're furry, right? Like on the human side, if
Right,
you're taking a bath, that's great. But if you're covered in hair too, I don't know how that really affects the load. Or if you have a bath and then you go for a swim in the bog before your surgery. I don't know. But
right, right.
consider.
It was just because, like we're scanning, we do so many pre-surgical ultrasounds,
Mhm.
and other things, and I just was curious about that. And
I
then,
was thinking when I was putting this together, I was thinking maybe when we're doing like a hemoabdomen or something like that, you guys are ultrasounding and then we're getting surgery for it a couple hours later. Maybe we should have you guys just do a quick wipe across the belly with something.
yeah, and I mean,
Yeah.
yeah, like, and we try and do a decent, like, we're pretty, yeah, we can do a Chlorhex or we can do something in here and we're happy to do that. But I just was curious, like, if that changes things for you guys down there, like timing wise, in surgery and, and whatnot. Like, we try really hard, with clipper burn, and sometimes they just come to us with clipper razor burn and things like that. And some of them just have very fragile skin, but we try
Mhm.
super hard in our department to not have that happen in here. But I just was curious what we could do to help prevent or change things for you guys.
I've honestly been thinking that we should just slather stuff with Duoxo mousse whenever we shave them.
Okay.
The Pio mousse probably because it's antimicrobial.
And then my last question, I just was writing down while you were talking. Is this mostly like for are you referring to mostly like perioperative and skin type things and like deep wounds, or are you also like referring like how we would treat like a pyelonephritis and things like that too?
Um, well, I didn't do a deep dive into the urinary stuff because it's not as much my forte. Like the
Right.
resistant UTIs are definitely a huge problem. And I think that's something that we need to consider how we're treating that as well too. I'm gonna let the medicine people think
Yeah.
about that a little bit more, but that's a huge area of concern there. We're getting more and more super resistant infections, and that's something they're seeing in humans too. And so, should we maybe be considering antibiotics that are more highly excreted in the urinary tract to get a better local effect? Um, I don't know, maybe. But we really should at least be getting cultures, I think, more often. This may be a little bit more related to the GP side of things, but don't just treat a UTI with an antibiotic. Get
Oh
a
yeah.
full urine cytology and then also get a culture for sure.
Right. Okay. Yeah, I just wanted to make sure that this was mostly like a
Hmm.
peri-operative, peri-surgical, major wounds, deep tissue type things versus like a systemic where we're treating like for whatever, other than like septic abdomens, obviously, which are going to go to surgery, but like
Yeah.
just curious for just my mental type thing.
One thing that came up at the soft tissue conference I was just at last week was nebulization and pneumonia. Should we be nebulizing antibiotics for pneumonia patients so we kind of get the antibiotics more effective that way? Nobody really had any good answers, but granted, this was the soft tissue surgeons. It wasn't medicine folks or anything like that, but
Yeah, I mean, when I was in medicine, we used to nebulize other types of things to help get down there too. So,
Mhm.
it's been a while, but I don't, yeah, I mean, maybe we can get one of the doctors to talk to us about that. We have this year booked, but we can certainly do more than one. So,
Mhm. Of course, the
Tech,
problem in veterinary medicine is always data, right? Do you have any studies that say, is it safe and is it effective? And we almost never
right,
get to get those studies, so that's the tough
right.
part.
So
I have a
anybody
quick
else?
question for you. I had people come in my office, so I might have missed this, and this might have been covered. But what is the criteria or the proper protocol for the collection of culture? And since culture for like wounds that come in through the ER, is it like on presentation, or should it be like as they're exploring the wound? Is that something that you talked about and I missed?
Just briefly. So I would try to get what you think is the most representative sample. So not necessarily on the skin margin or something like that, but a deep sample within where the you think the main part of the infection is. Um, Some people are big on cleaning the wounds first and then getting a culture. The only downside with that I find is if you're cleaning it with chlorhexidine, then that will have a residual effect and can affect your culture results, can kill off some of the bacteria. So flushing for sure, just like get sort of to where you think the infection is and get it cleaned out a little bit and then get a deep sample from wherever it is. Usually surgical samples are the best rather than just a superficial swab. If you get something like an incision that comes in, it's got a little pocket of something in it, then go ahead and just stick a swab up into that pocket and get a sample of it. Like for example, a TPLO incision or something like that. And then I like this chart. I can put this somewhere else about what containers and stuff to put it in.
Does anybody else that's still online have any questions? You can unmute yourself if you need, or you can put it in the chat, whichever. Um, doesn't appear so. I know that last month Dr. Beulah did a talk about wound care, and she also mentioned the same thing, that she would prefer a surgical culture versus right through emergency, and um if it's going to go to surgery, she would prefer also a surgical culture, and not doing it as they walk in the door because it may not be the best answer either, and that we would have to change our results based on surgery as well.
It just like in an ideal world, like on the human side of things, culture it when you walk in the door, they culture it whenever they do a surgery, they culture it before they close it. They're doing so many serial cultures, and that would be ideal. Financially, it's hard to sometimes talk the clients into that. So I think for a wound that's coming in, it really depends on when you think the surgeon's going to be collecting the samples? When are we going to be getting a culture? Because if it comes in on a Friday and it's not going to have any wound stuff with a surgeon until Monday or Tuesday, then I would get a culture on Friday, so we at least have some results, hopefully early in the week, the next week. But if they're going to go to surgery in like 2 hours, then might as well just wait for those culture results. Wait for surgery, sorry, to get your culture.
Right. Otherwise, we don't have any other questions. Your talk was excellent.
All right, sounds good. Well, anybody come find
thank
me
you.
if you have questions.
Yeah. Thank you very much, Dr. Retallack.
Yeah, you're welcome.
Thank
Take care,
you.
guys.
Yeah.
Bye.
Have a great day, guys. Bye. Thank you for coming, everybody. I have everybody who was logged in, your name, if you're still here. Everybody who's on the screen right now is all logged in. Bye, guys. Bye.